Hi, this is Nobel. I'm presenting today's afternoon report. Hopefully you'll find it interesting. So I'm starting with chief complaints. So 79-year-old African-American male presents with 3 days of nausea and vomiting. So with this much of information, what would you like to ask the patient?
Any blood or bile?
Did you hear that, Nobel?
Yep.
Sidra asked a question.
So patient said that he had dark color emesis, no blood. He has some substernal pain, but no other abdominal pain, no sick contacts. So accompanying symptom is patient cannot tolerate pure food or liquid. No fever. Last bowel movement was 3 days ago. Okay. So he gave these. So these are the information. So dark color vomitous and unable to tolerate pure food or liquid. Okay. So now with it, as the patient is saying that patient is having dark color vomitous, what else you would like to ask?
Abdominal pain?
No alcohol use. Yeah, looks like coffee ground, black color. No alcohol use. NSAID use, yes. Medication. So I'll give you the list of medication. So patient has been taking ibuprofen.
Let's
How
move
much
to
and
the-
how often?
Yeah.
Yeah. So patient was actually last admitted a couple of months ago. At that time, patient was here for failure to thrive, and patient had back pain. Patient was discharged to SAR. When he went to SAR, he was taking ibuprofen 400 milligram 4 times a day. So he took it more than 30 days. No known history of gastric or duodenal ulcers. So 3 days of nausea, vomiting, dark color vomitous, unable to tolerate pure food or liquid, denied similar even before, no history of alcohol use. I mean, rarely, 1 drink a month, no retching, no hematophysia, no melanoma, or no anticoagulation use. Complaints of substernal pain with that episodes of emesis, but no other abdominal pain otherwise. Okay. So these are the past medical history. Patient has hypertension, type 2 DM, CKD stage 3, HIV well controlled. These are the counts from July this year. And patient was seen in October. Hyperlipidemia. Patient had history of repair of inguinal hernia and umbilical hernia on 2018. History of cholecystectomy on 2020. Patient had 2 procedures done, colonoscopy, 2 polyps removed on 2018. And upper GI endoscopy was done for workup of pancreatic cyst. It was found to be benign. It was in 2017. At that time, they also saw paraesophageal hernia at that time. Otherwise, patient lives alone. Patient has home health aid at home. No smoking or illicit drug, alcohol, 1 to 2 drinks in a month. Okay. So, yeah, these are the list of medication patient is having, and these are the medication associated allergies that patient has. So you already asked about NSAID, ibuprofen. So 30 days of 1600 milligram of ibuprofen patient was taking. Okay. On review of system, it was only remarkable for nausea, vomiting, dark color vomitus, and constipation. And patient has also back pain, for which he was taking the ibuprofen. Otherwise, it was unremarkable. This was the initial vitals when the patient was in the ED. So BP 134 over 88, pulse 89, no fever, respiratory rate 20, SpO2 98%. So on physical exam, patient was not in acute distress. He looked very weak, malnourished. And here on ear, nose, mouth, throat examination, we could see dried black specks or spots over his lips, tongue, and oral mucosa. And dark color vomitus was seen in vomit bag. So this is the vomit bag. Okay. Otherwise, with patient cardiovascular wise, regular rate and rhythm, no murmurs, no peripheral edema, lungs were clear, bowel sound was present, soft, non-tender, non-distended, and no rebound or guarding. No palpable tenderness over back, no joint effusion erythema, no skin rash, otherwise neuro ANO times 3.
Let's just pause, go back one slide. Let's just pause here for a second. Any more questions in the history you want to ask, or any other examination findings you want to inquire about? What other
Any
things?
history of weight loss? Sorry.
No recent weight loss. Patient had history of weight loss way back, but not any recent one. No crepitus, epigastric pain. So that's substernal pain that is associated with vomiting.
Kavya, what do you mean by crepitus here?
I was wondering if there was concern for like esophageal perforation. So like crepitus near the neck.
Okay.
No crepitus.
All right. Anything else? Anything on history? Anything on examination you would want to do in this patient? Pallor. Okay. Anything else?
I know his bowel movement was 3 days ago, so like any melena, would you want to do maybe a rectal exam?
Excellent, excellent. So why is it important in this case, Raj? Why is a digital rectal exam important?
If you're suspecting GI bleed, upper GI bleed, there's possibility, or any kind of GI bleed, there's a possibility that it might be coming from rectum as well.
Excellent, excellent. Then I see somebody in the chat wrote orthostatics. I don't know who Romain and 9th floor is, but excellent point. Whoever that is, you want to take credit for it? Okay, credit doesn't go to anybody, but that's an excellent point. Orthostatics is extremely important here. Would you like to elucidate why, or would you like to explain why it's important? Student on silver team important for management. Excellent. So yeah, you know that vitals can be deranged in a patient with a hemorrhagic shock or with a bleed, but orthostatic is one of those. It's one of those data points you have pointing towards hemorrhagic shock. Excellent point. We'll talk more about vitals later. So anything else anybody wants to ask in the history? We talked about examination. We want to know more about orthostatics. We want to know more about the digital rectal exam. Any other historical points which will help you, number one, come to a differential diagnosis, or number two, help you guide your initial management? Somebody already asked whether this patient has a previous history that we know about. Anything else? We asked about alcohol use, we asked about smoking, and something else along those lines.
Yes, history of HIV. Yeah, colonoscopy was in 2018.
Yeah. He did talk about the colonoscopy. It was in 2018 and two polyps. Right. You also want to know about, okay, IV drug use is important error. How would that help us?
One of the sexually transmitted, like hepatitis, HIV, one of those. I was thinking along those lines.
Yeah, so he could have chronic hepatitis, which would lead to liver disease. So on those same lines, liver disease is number one, could be because of alcohol, could be because of other things. So you want to see if he has any history of decompensated liver disease or any other thing which would point towards liver disease, like abdominal distension, if he has any family history of liver disease, if he's on any drugs which could cause liver disease. So that's what you would want to know. All right. Going to the next slide, can we just see that picture again? What would you like to describe this as? Anybody want to give this a more, a better descriptor? Something we use more commonly in like a medical setting rather than just calling it dark. Excellent, coffee ground. So it's important to label this as what it is. It's coffee ground emesis. All right. We can go to the next slide.
Okay, so in this patient, what labs would you like to get? CVC, tap and screen, BMP, LFT, coax,
Excellent.
lactate. Great. Yeah. So these are the PBG lactate, creatinine, creatinine, fibrinogen.
Yeah, no, all of these are good points. Just let's see the labs now.
Okay, so these are the initial labs. So hemoglobin was 12.5. From 2 months before, his baseline was 13. Platelet was 143. These are the electrolytes. Creatinine now 1.42. Baseline is around 1.12. BAN 44. GFR 47. Calcium 11.3. These are the labs. Liver enzymes, alpha 78, AST22, ALT14. INR is not elevated. There is a slight bump in troponin.
All right. Anything else anybody wants to ask? Baseline troponin. I think let's shelf that for a different date. I mean, obviously, this patient is having a GI bleed, so there'll be some kind of supply-demand mismatch. So we're not going to talk about troponins today. Anything else? Platelets a bit low. Okay. Anybody want to talk about anything else here? Anything in the labs which helps them consider something or make something lower in the differential? Yeah, good point from Marilo. BU1 creatinine greater than 30 suggests upper GI bleeding. Is it greater than 30 in this case? If somebody calculates, it is, right? Yeah, probably is. I'm not going to do the maths right now. Then, as somebody rightly pointed out, platelet count is slightly low. What implications does a low platelet count have in a potential GI bleed patient? So in a patient who has GI and who has hematemesis, one of the most important differentials is liver disease, and it's variceal bleeding. So the things on the labs you will see in a patient with chronic liver disease are low platelet count, so thrombocytopenia because of hypersplenism. What other things would you see on the labs? Anything else you would see in a patient with cirrhosis?
Yeah, so altered coags, high uremia, thrombocytopenia, low albumin, all of that could lead us to think liver disease.
Good, good. So hyponatremia is also one of those things. LFT derangements could be seen depending on the degree of acute injury, and then hyperbilirubinemia, as Kavya was actually mentioning.
Also, I think it's higher than 30. It's 30.9 or something like that.
So that points us towards the upper GI. Right. So
also,
let's talk.
A retic count in the patient.
A retic count. How would that help in this case?
Usually, if a retic count is not appropriately elevated, that means it's an acute bleeding that the patient is having.
Yeah. But in this patient who you see massive bleeding or like you see blood, that means they do have acute bleeding, right? So the retic count is more useful in patients with anemias where you want to diagnose why the anemia is happening and when they don't have an overt source of bleeding. In this patient, you have an overt source of bleeding. So a retic count isn't that helpful because you know that patient is losing blood. Let's see the next slide. Let's talk about the problem representation now, right?
So this was the initial chest X-ray that was done. Do you see anything remarkable here?
What's important to see in a chest X-ray in patients who present like this?
And
What are you worried about?
Widening to rule.
Subcut emphysema.
Right, free air, good. What else?
Widen mediastinum, upper.
Okay, I mean, that's something you could see, but it's not very sensitive or specific for anything. But yeah, definitely it's something you could see. Jessamine points out aspiration, exactly. So in these patients who are having hematemesis, one of the things you're worried about is airway protection. They can aspirate all of that blood and that can lead to aspiration pneumonia, hypoxemia, and that can actually cause death. So that's something you have to be very worried about. In this patient on the right base, we don't see anything, it's clear. So airway has been protected. All right, next.
So can anyone try the problem presentation?
Because yeah, like this. Let's see. Jin, you want to help us?
Can I take a look at the past medical history again? Oh, thank you.
So I'll help you. So who is the patient? Can you go back one or two more slides? What age group?
9-year-old male. So history of HIV.
So let's characterize it. What age group? We don't want to talk about like what number, but what age group is he in? What?
A senile patient.
Elderly patient, right? Senile is kind of, we'll talk about that later. So elderly patient, and then what prominent or what important past medical history does he have? Can we go forward to one more slide? Yeah.
So no history of liver disease with past medical history of CKD stage 3, HIV, but well controlled. Also other comorbidities include hypertension, type 2 diabetes, hyperlipidemia.
Yeah. So let's take it slowly. So important things, you said it very well. You said no history of liver disease. It's as important in the problem representation to know what the patient doesn't have. So in this, a patient without liver disease. So that's I really like that you said that, no history of liver disease. Then what he pertinent history he does have is CKD, which could be important. We'll talk about later. And then history of hypertension and HIV. All right. So we know who the patient is. It's an elderly patient with these comorbidities. Now, what clinical syndrome is he presenting with, and in what temporal or what time period?
So he presented with nausea, vomiting, with coffee ground, hematemesis for 3 days. So
that's right. So the clinical syndrome is coffee ground emesis. So we know what he's presenting with. Anything on the examination, or let's go to the vital slide. Is there anything you want to clarify here? Is he in shock? Is he not in shock? Is he hemodynamically stable or unstable?
So for hemodynamically stable.
Good. So we see that his pulse is 89. Can we go back to his medications? Any medications which might be interfering with that?
So he's been taking metoprolol, so that could mask his tachycardia as well.
Excellent, excellent. So one of the most early signs of hemorrhagic shock is tachycardia. And if it's a patient on a beta blocker, that tachycardia might be masked. So as of now, based on the blood pressure, you would say that the patient is not in shock, but given that he is on a beta blocker, you have to still be, you can't say that the patient is completely out of the woods. So we know who the patient is, we know what clinical syndrome he's presenting with, and can you tell us what other risk factors he has which could be leading to this? We talked about
habits. He has no history of alcohol abuse, no history of IV drug use, so less likely to have viral hepatitis.
Something very distinct which stood out in his medication history. He had a recent hospitalization for pain. So what is he on?
Also, he's been taking ibuprofen. That could put him at higher risk.
So that's an NSAID. So he is an elderly male we talked about the past medical history who's presenting with coffee ground emesis for 3 days with known liver disease, but with significant NSAID. So that paints a picture, right? So you know that, okay, this is a patient, elderly patient, NSAID use, no liver disease, presenting with coffee ground emesis. So that paints a picture and that helps you guide your management. So that's, you want to know who your patient is, what age group and what comorbidities, what's their clinical syndrome, and what is the time period. And we also talk about important things in the examination. So the important thing in his examination is hemodynamically stable. So Nobel, can you help us with what you drafted?
Sorry. From presentation. Okay, so an elderly African American male, so past medical history, DM, hypertension, well-controlled HIV, hernia repair, cholecystectomy, recent high-dose NSAID use, no history of liver disease, presents with acute onset of nausea, vomiting, coffee ground emesis, substernal pain during periods of emesis. So on exam, is tenuous, so there is dried black specks on lips, tongue, and oral mucosa, and also evidence of coffee ground emesis in the vomit bag. Patient is hemodynamically stable. So
all right, no, let me share my screen. Let's talk about GI bleeding now. All right, so we know that this patient presented with coffee ground emesis, so the patient has GI bleeding, but let's talk more about GI bleeding in depth. I did not choose this color, it just chose on its own, but it's kind of apt. So let's talk about some definitions first. So what terms do you know for manifest GI bleeding? Let's talk about what this patient has. Hematemesis. Anybody want to take a stab at what hematemesis is? Or how would you define, or what can you see in hematemesis? Adrian, can you help us?
Sure. Hematoma, just basically vomiting up blood.
Excellent. And what did we see in this patient?
So we saw coffee ground emesis. So we saw dark upper GI type blood.
All right. So hematemesis doesn't just mean that you have bright red blood. You can have blood, or you could also have coffee grounds. So both of those would come under hematemesis. Good. How else could you see manifestations of GI bleeds? Anybody want to give us another example of a GI bleed, or what you would
Melena.
see? Excellent. Who said that?
Galit.
Okay. Hey Galit, can you tell us
Okay.
what melena is, or how would
So
you describe it?
it's basically black stools.
So I want you to
Very
always, when
Yeah.
you talk about melena, you have to talk about two words. It's always this and it's always tarry. Excellent.
sorry.
It's always black and always tarry. Lots of times you ask the patient what kind of stool they have and they say dark. Is that melena? No.
No
Melena
necessarily.
is black and melena is tarry. Paint a picture. It's important. It's black and tarry. If it's dark, it is not melena. And melena doesn't necessarily have to be manifest. You can have melena when a patient passes a bowel movement. You can also have melena, which you see on a digital rectal exam. So both would qualify, but one way to differentiate it on a digital rectal exam, when you're not able to, you do a digital rectal exam and you can't see whether it's dark or it's black and tarry. What you do is take a white chalk or a white tissue paper and you smear your digital rectal exam on it. If it's on this white background, if it's dark and if it's black in color, then it's melena. All right. Any other way you can manifest or you can show a GI bleed?
Hematophysia.
Excellent. Can you tell us what hematophysia is?
It's red or maroon stools.
Excellent. So hematophysia is blood in stools. So we talked about these three forms. Why is it important to know these three forms? How does having one from the other differentiate or help us to come to a differential in a patient?
It helps us to differentiate whether it's upper GI bleed or a lower GI bleed.
Excellent, excellent. So what is upper, what is lower?
Yeah.
So I see Abigail says in the chat the ligament of Treitz. So that's excellent. That's what divides upper from lower. But we are talking about how they would manifest. This is the ligament of Treitz. All right, does anybody want to talk about, okay, so hematophysia comes from more distal bleeding and melena comes from more proximal bleeding. Okay, we can take that. So melena is seen in upper and hematophysia is seen in lower. Is this exclusive?
Massive upper GI bleeding can also present as hematophysia.
Excellent. So that's very important. If you have a patient with hematophysia who is hemodynamically unstable, you have to consider upper GI bleeding on the differential, because it might be the speed or the rapidity of the blood loss is so rapid that it doesn't have enough time to get digested, and that's why it's just purging out of the system and not having time to become acid hematite. Can melena be from a lower GI bleed?
Unlikely.
I agree, it's unlikely, but it depends. So if if it's a proximal or if it's a right-sided colonic bleed and it is slow, if it gets enough time, it can also get digested by the secretions coming down from the gastric mucosa into the colon, and it can become digested and become melanoma. But it would have to be a very slow bleed. So it's not what you would consider on your the top on your differential, but it's possible at the same time. All right. Why is it important to know whether it's an upper or a lower GI bleed?
Because you have to know whether the patient would require an upper endoscopy or a colonoscopy.
Excellent. And so you would do a EGD versus a colonoscopy. What else? What does it have any other implications apart from what procedure you would do? Suppose every patient got an EGD and a colonoscopy. Why is it still important to know? Like if you were a patient or if you were a patient's relative who had a GI bleed, why you want to know whether it's an upper or a lower?
For an upper, like it's different etiologies. So there's sometimes different management. Like if you're concerned for varices, you have to start things like Octreotide and SPP prophylaxis.
Excellent, excellent. Also for prognostication, is it important? Which is more deadly? Which is your mortality higher in an upper GI bleed or a lower GI bleed?
I think it's upper.
Excellent. So mortality in an upper GI bleed is 3.5 to 10%, which is pretty high. And in a lower GI bleed, it's less than 4%, so it's 2 to 4%. So you see there's a big difference in the mortality. So that's why if you have a patient with an upper GI bleed, you have to give them, you have to consider screening them to the ICU depending on other factors. And lower GI bleeds tend to have lower mortality. Management is different, procedures are different, and medications are also different, right? If you have an upper GI bleed, you might treat them with pantoprazole or some octeotide depending on the risk factors, but a lower GI bleed, a PPI would not help at all. Lower GI bleeds tend to have very few endoscopic interventions. So if you have a lower GI bleed, if you have diverticulosis, they're usually self-dissolving and there's no endoscopic or very few endoscopic treatments you can give them. But in upper GI bleed, vast majority of cases, if it is a true upper GI bleed, you can do an endoscopy, which will give you a differential, which will give you a diagnosis, and you can also do treatments on it. So that's why it's important to know upper versus lower. Murillo was telling us about BON creatinine ratio. How does it differentiate between the two? Can you I just want to emphasize that again. Murillo?
Okay. I think it's associated with the digestion of urea. Could increase the products so for this reason, increase the fraction between urea and creatinine.
Excellent. So it's BON creatinine ratio you want to see. If you're having a patient whom you're for some reason not sure whether it's upper or lower, you calculate BON by creatinine, and if it's greater than 30, high index of suspicion for an upper GI bleed. And the reason you said is yes, because the blood gets digested and it leads to elevation of BON. All right, so we know definitions, we know upper versus lower. Now let's talk about initial management and what you would actually do when you see one of these patients. So let's talk about vitals. We talked a little bit about it earlier, but what are you worried about in these patients? What will they die of?
Volume loss?
How would you rephrase that? Is it
blood loss?
So yeah, hemorrhagic shock, right?
Yeah.
So it's hemorrhagic shock. All right, so you're worried about hemorrhagic shock. So what's the first thing you would see in a patient with hemorrhagic shock?
Hypotension.
If this patient were to decompensate, what would be the first thing you would see, first change you would see?
So the first change would be tachycardia.
Excellent. Sinus tachycardia. As Roberto was talking, first thing you see in a patient with hemorrhagic shock is tachycardia. And for tachycardia to be seen, you can, even if you lose less than 15% of your blood volume, you can see tachycardia. What's the second change? We talked about it a little bit. One of the excellent students in the silver team gave that answer. So, I mean, obviously the last is frank hypotension, for which that means you've lost 40% of your blood volume. So what's the change you see in patients between from 15 to 40%?
Cold extremities, maybe?
Cold extremities is, it's not a, yeah, that's something you would see in shock, but something on the vital signs you would see in this patient. We just talked about it. I want to emphasize on the fact that it's an important vital sign. All right. Orthostatic hypotension. Somebody who has lost more blood than, not enough blood to become hypotensive, frankly. If they have orthostatic hypotension, that means they're getting there. They're getting sick. So you have to take those patients very seriously. So we know this patient, we know a patient might have shock depending on, you know, has tachycardia or not. So what are your first, before you go into, you know, I'm going to call GI, what are the first things you should do in the emergency room? What are things you can do to save this patient? And usually the answer to these things is very simple. It's always ABCD. Always protect everything. Think ABCD. This is like standard answer for every question about, you know, emergency management. So certain nuances in these patients. What kind of, so they're going to die of hemorrhagic shock if they're going to die. So what do you do to prevent that?
Fluids, give the patient fluids.
Okay. And how will you give the fluids?
IV fluids.
IV. So you need to have first step, IV lines. Any patient with hemorrhagic shock, it's extremely, extremely important. First step, ensure they have 2 large bore IVs. And what do I mean by large bore?
18 gauge or larger.
Exactly, 16 to 18 gauge. If I have a patient with a central line versus a patient with a 16 gauge, if I have a patient with a triple lumen, suppose I have a patient with both, what would you give the blood through?
Probably through the 16 gauge versus.
Why is it better than the central line?
Because the central line has it's like has to do with resistance. So the central line actually, because it has 3 lumens and because it's longer, you're actually not, your flow rate's going to be slower than just like a peripheral 16 gauge.
Excellent. So resistance is dependent on the length as well. So, and it's dependent to the third power. So a longer line as compared to a shorter line would have, if it's like a difference of 2, it would have 8 times higher resistance. So in patients who are bleeding, giving fluid or blood through a short 16 gauge is much better than giving it through a normal central line. But the only caveat is if you have a patient whom you can put a cordis in, which is a thicker central line, which has its own set of complications, but it's a specialized line used in patients with hemorrhagic shock, especially in trauma patients. That's a huge caliber central access, so you would use that, but that's a separate topic. Those are put in by emergency medicine and critical care physicians, so not something you'll be putting in on a regular basis. So just remember, if you have a patient who you have a night float with hemorrhagic shock or with GI bleed who can decompensate into hemorrhagic shock, make sure they have at least 2 IV catheters and at least 16 to 18 gauge. Lenny said you can give them IV fluids. Excellent. What fluid would you give them?
Yeah, someone said crystallosis, 0.9% saving.
Sorry, crystalloids, good answer. But what are they losing? So what do you immediately, I mean, even though we don't have it immediately, you would start with crystalloids, but what's the end goal? You want to replace that blood with blood, right?
Replaceable.
So transfusion. Crystalloids just buy you time. They're not going to replace what the patient lost. So in a patient who's losing, crystalloids is just a band-aid. Once you stabilize the patient, it is essential to give them blood. So now that we are talking about—
I have a question. Mm-hmm. In this patient of the case with this type of emesis, do you think about intubation right away to protect the airway, or you just wait? Or is there any other different than intubation, something else that you can do to protect the airway?
Good question. So that is not as, it's not a black and white answer. So the things you want to take into consideration are, number one, is the patient awake enough and stable enough that they can protect their airway on their own. So if I have a patient who had a massive GI bleed, is in such shock that they're not able to protect their airway, you would obviously intubate. Somebody who's having ongoing hematemesis, the hematemesis hasn't stopped. They had it once, okay, you're trying to sit and see, wait on it. But if they have it again, you're worried that it's not stopping, it's not relieving with your medical therapy, you want to protect the airway. So those patients also, you would protect the airway. And number three, if you have somebody whom you think might has stigmata of liver disease, is cirrhotic, in those patients, variceal bleed is high on the differential, and variceal bleeds tend to be large volume and they do not relieve on their own. So the mortality is very high. So in those patients as well, you should have a low threshold for intubation. All right, does that answer your question?
Yes, but how about this patient?
So in this patient, he's hemodynamically stable. He's able to protect his airway, and he's had a little bit of blood loss, and now it's stopped. So I think it's fair to say you don't have to rush to intubate right now. But if he had another episode of bleeding while you were examining, you would say, okay, now that's my threshold. I'm going to call anesthesia, and we're going to get him intubated.
Okay.
It's kind of a clinical gestalt, but you have to kind of make sure that, number one, you're paying close attention to vitals, and number two, you're paying close attention to what the patient's differential is. So if you think this patient has hematemesis because of a variceal bleed, even at this stage, you wouldn't be wrong to intubate.
Thank you.
All right. So let's go back to transfusion. So what are the indications for transfusion? So when would you transfuse this patient? We saw that his hemoglobin was, I think, 12.5. Would you transfuse this patient?
Hemoglobin should be less than 7. Oh, someone just typed it.
Yeah, all right. So let's talk about strategies for transfusion. So we've had a lot of data and a lot of studies which try to ask this question and answer this question. So what liberal transfusion means is you give the patient blood. You have a higher transfusion goal, you give a lot of blood. And restrictive means that you just give, number one, if the patient is hemoglobin less than 7, or if the patient is hemoglobin is less than 8, and the patient has active cardiac disease. And some studies did randomized controlled trials on this and tried to compare the outcomes. And as what happened in these trials was patients who had restrictive strategies actually had better outcomes. Could somebody tell me why a patient with like transfusion, even though you're giving them blood, you're making sure they're not in shock, would have a poor outcome? Why would their mortality be higher? Any ideas? What harms can this cause?
Can you repeat the question, please?
Why? So in studies which evaluated liberal versus restrictive transfusion, it was seen that patients who were given more transfusions actually had worse outcomes. And why is that? So I do see a few answers in the chat. So exactly one of them is transfusion reaction. So, blood products are not benign. They can cause a lot of reactions. They can cause volume overload, circulatory overload. They, in the past, used to cause infections, hepatitis, so transfusion-associated reactions. You can also have anaphylaxis to blood products. And then patients with cardiac disease, if you over-transfuse them, they're going to have volume overload. So that's why it was seen that restrictive strategy, where you transfuse for hemoglobin less than 7 or less than 8 with active cardiac disease, are actually what you were doing. Excellent point by Raj. You're also leading to wastage of valuable resources. Blood is not an infinite resource.
A question in regards to this. So if you have someone like in a patient that's hemodynamically unstable, and they're presenting, let's say, to the ED, you don't have labs yet, you don't have a hemoglobin, but he's clearly in like hemorrhagic hypovolemic shock, do you just assume, like, do you just give blood out of just like this liberal method if you don't have the hemoglobin, but you know this person's like actively crashing and hemodynamically stable?
Yeah, excellent point. So that's what I was going to talk about next.
Oh, sorry about that.
These studies evaluated stable patients only. They were all patients who were hemodynamically stable. If you have a patient who is hemodynamically unstable or a patient who is hypotensive, those were not the patient population study. So if you have a patient who is unstable, you do not need to wait for a hemoglobin, or you do not, if you have a patient who is having ongoing bleeding, you transfuse. Ongoing bleeding or hypotensive, hemodynamic instability, you do not have to wait for a hemoglobin, you just transfuse. That population is not a part of these randomized control trials. So those are patients, that caveat is if a patient has ongoing blood loss with hemodynamic instability, you transfuse, you do not wait for the hemoglobin. Right? So you would, in a stable patient, you would transfuse for these two indications. In an unstable patient with ongoing blood loss, transfuse. Any questions about that? Right. So let's talk about risk stratification scores now. So we have this patient, we want to know, we have this patient in the ED. They've stabilized him hemodynamically, they've called GI. Now, where does this patient go? Does this patient go home? Does this patient go to the floor? Does this patient go to the ICU? Wanjun says floor. Anybody wants to disagree? Why do you say floor, Wanjun?
Just because patient is hemodynamically stable. Also, the hemoglobin, I'm sure will trend it, but doesn't seem to be in any acute or active ongoing bleeding.
Yeah, good points, but that's your gut, right? Okay, this patient is stable, this patient might, but what happens if what tells you that this patient is not going to become unstable in the next 2 hours? Is there anything we can use, any tool we can use which can pool data from previous patients and see which patients had what mortality so that we can make better and more informed decisions? Anybody know of any scores or any tools we use for GI bleed patients to see where they should go or see what kind of mortality they have? All right, let's talk about some scores. So the first score I want to talk about is the GBS, Glasgow-Blatchford score. So these are validated scores. These are derived from well-validated data, which gives us mortality based on some parameters which we put in those scores. Let me just, let's just do an exercise. Let's open MD Calc. So can everybody see this? Okay, how about now? All right, so this is a bleeding, this is a score which helps us decide whether this patient's mortality is high or low. So let's plug in the numbers here. What's the hemoglobin? 12.5, right? Anybody want to help me with the BUN?
BUN was 44.
Systolic blood pressure?
There's 133.
Heart rate was not more than 100. Melena was, we don't know, we didn't do a rectal exam, but let's say this patient had melena. Syncope, no. Hepatic disease, no. Cardiac failure, no. So this patient has a GBS of 6, and 6 suggests high risk. So does, going back to our discussion, according, all right, I won't belabor this, but patients with a Glasgow-Blackford score of 0 to 1 are extremely low risk. Based on validated data, their chances of needing endoscopic therapy or needing ICU admission is less than 1%. So these patients, if you have a patient who comes to the ED with some overt GI bleed, which like based on history, whether it's melena, it's hematemesis, if their GBS is 0 to 1, data has shown that you can safely discharge them home and they can follow up with a gastroenterologist as an outpatient and get an outpatient score. Any patient with a score of greater than 2 needs to come to the hospital. So that depends on how what other risk factors the patient has. Higher the score, the higher the mortality, the higher the likelihood that the patient is going to be needing endoscopic therapy, and the higher likelihood that the patient needs to come to the ICU. So that's one risk stratification score. Any other score anybody knows about? I mean, you just need to use one. I just want to make sure you have the tools to make proper risk assessments. So Glasgow is, if you're comfortable with Glasgow, just use this all the time. Others are the Rockall score. And there's AIM-65. They use different variables, but you don't need to learn any of them. Just open MD-Calc, plug in the numbers, and try to get an assessment of how high the risk is for my patient to decompensate or to have mortality. And as I said, why is it important to know the mortality? Number one, does the patient need to be admitted to the floor? Does the patient need to go to the ICU? And how quickly do I need GI to come and see this patient? All right. So now let's talk about our differential for this patient, or differential for upper GI bleeds in general. And we in medicine always like to have schemes, or we like to have certain diagnostic frameworks. So any major framework which you can use to divide hematemesis or GI bleed patients, any two major categories? We've been talking about it, but
or gastric?
Gastric is broad. So can you make it a little more nuanced? So what do you have in esophageal? What kind of pathology?
Could be a Mallory-Weiss tear, a tumor.
That's one division, but we want to focus on a division which helps us manage. Like we have to fold patients into two groups which have distinct managements. Because a patient with an esophageal mass and a gastric mass, like it wouldn't really lead to differences in their management. So what I was referring to was variceal versus non-variceal, because they have very, very different managements, and they have different mortalities, and they have different therapies. So let's talk about variceal. Whom do we see variceal bleeding in? Yeah, Raj says portal hypertension. So it's liver disease patients. As I said, these patients are sicker. They have some history of liver disease, and they are managed differently. Sidra had told us a little bit about this earlier. Sidra, can you tell us again why they are managed differently?
So with variceal bleeds, you want to think about like splanchnic, like blood vessels. So octreotide helps with that. And then you also want to think about SBP. So for prophylaxis, you give like ceftriaxone.
Excellent. So you give ceftriaxone for SBP prophylaxis. Anybody want to tell us how you give octreotide? Octeotide is given differently for different indications. So for GI bleeds, you give it IV. You give an IV bolus followed by a drip. You can give subcutaneous octreotide for different indications, but important, IV octreotide is important, and you need to start, if you have a suspicion for liver disease in a patient, you start this even before endoscopy. You don't wait till endoscopy to see that the patient has varices or not. If you think this patient has some stigmata of liver disease, you start octreotide, you start SBP prophylaxis. This saves lives. This improves mortality. It's as important as PPIs. And PPIs we give to every patient. We can talk about PPIs later. All right. So non-variceal bleeding. What are the causes of non-variceal bleeding? What's the most common cause of a non-variceal GI bleed, upper GI bleed?
Peptic ulcer.
Ulcer. Ulcer. All right. Other causes? We'll talk about ulcers a little bit later.
Malignancy.
Masses, malignancy. They could be gastric, esophageal. Anything else? Yeah, Sonal says Mallory Weiss. We asked, Nobel asked a very good question in this to rule out Mallory Weiss, right? He asked retching. So Mallory Weiss has classic history. You come with retching. You initially have bloodless vomiting, and then you have bright red blood. Anything else which can cause upper GI bleeding, which is not an ulcer, not a mass, and not a esophageal varices? Yeah, Vanjun says esophagitis. And in the same boat comes gastritis. But these usually don't present with life-threatening bleeding. Esophagitis and gastritis can cause minor bleeding. Murillo says angiodysplasia, so AVMs, Dieulafoy's lesion. All right. And trauma, yeah, depending on that would be very apparent if the patient has massive trauma and causing some kind of viscous perforation. So we have a good differential, which is pre-endoscopy, and then post-endoscopy, our differential will be based on what we see. A little bit about ulcers, because ulcers are the most common cause of non-variceal, and I think even the most common cause of upper GI hemorrhage. What are the risk factors? What would you see in the history of a patient with an ulcer? NSAIDs, excellent. This patient has classic overuse, NSAID overuse, recent hospitalization for pain, discharge with high dose NSAIDs, and then comes with GI bleed. This sequence you would see in a lot of patients. Excellent. Vanjun, H. pylori. It's one of the most common causes of peptic ulcers. So any patient who comes in with a GI bleed, you see the patient has an ulcer, or if the patient comes in with GI bleed, gets an endoscopy, you must check for H. pylori, because eradication of H. pylori in these cases would prevent from rebleeding in this patient. All right, anything else? Anything we talked about NSAIDs, any other medications? Good point from Sonal, stress in critically ill patients. Steroids, good. And then we also want to make sure the patient is not on anticoagulants, other antiplatelets. All right. How do we classify ulcers? And I mean, we've talked about 2 or 3 classifications already, but it's important in this case, and I'll show you why. Anybody know what the classification for ulcers is? It's called as the Forest classification. And this is not something you can classify without an endoscopy. This is something you see on endoscopy. Forest classification. Let me just show you MD Calc. So this is the Forest classification. So Forest 1A is actively spurting blood from an ulcer. 1B is active oozing, it's not spurting. And a spurt would be an arterial bleed. You would see like the blood comes and then stops, comes and then stops, like an arterial bleed. Oozing is slow, regular oozing, or oozing which doesn't stop. Then we have Forest 2A, which is a non-bleeding visible vessel. 2B, which is an adherent clot. And 2C, which is flat pigmented spot. These mean that the patient was bleeding, but now the bleeding has stopped. And then you have Forest 3, which is a clean ulcer base. What I wanted to show in this MD Calc is you see the mortality difference. Forest 1A, history chances of rebleeding are 55%. It's more likely than not that the patient that will have bleeding again. So more likely than not that the patient will have bleeding again. That's extremely, extremely important, because those patients you would want to admit to the ICU. These patients should not be on the floor, because the chances of them bleeding again and dying and exsanguinating on the floor are very high. active oozing as well. So Forest 1 means this patient needs, even after endoscopy, the patient's on a PPI drip being managed, they still need to go to the ICU because the chances of rebleeding are so high. And then Forest 2, you see that rebleeding rates they just keep going down. So 43, 22, and then 10. And then mortality also goes down. So 11, 7, and 3. So that's why it's important to know, because you want to know how high your patient's risk of dying is and where the patient needs to go after the endoscopy. All right. So we talked a lot about management. So for variceal bleeds, we talked about octreotide, ceftriaxone, and then let's talk about the cornerstone of most GI bleeds, PPIs. So what are the ways you can give a patient a PPI in GI bleeds? Anybody treated a patient with a GI bleed on the floor in the ICU? IV?
You can give IV, you could give a drip, you can give PO.
Okay. So what would you want in this patient?
Stable, probably PO.
Or
actually, no, so sorry, they're being admitted to the floor. So IV bolus, basically, 80 milligrams.
So yeah, anybody with ongoing active bleeding, you can't go wrong with IV, right? IV, oral is for stable patients who are probably being discharged home. If you're sick enough to be in the hospital, you should be on an IV. But at the same time, the data is very equivocal and there is no large scale consensus. So the fact with PPIs is we don't have good RCTs to evaluate, number one, a drip. We do, but the data is so equivocal that there is no good consensus between whether a patient should get an IV PPI drip, IV PPI BID versus oral. Because there are studies which show both things. Some studies show that PPI drips and PPI IV BID have equivalent outcomes. Some studies show that IV BID and PO BID have equivalent outcomes, but they're not high quality evidence. So even in the guidelines by most organizations, they say that you can use an IV drip or an IV BID PPI, but most practitioners prefer an IV drip. So you can't go wrong with an IV drip. With the caveat that an IV drip will take away an IV line. So you have to make sure your patient has at least 2 IVs because one IV access is going to be with the drip. But at the same time, if you have a patient who's a very, very hard stick, you can't get an IV line. You just have one IV where the blood is running. In that patient, you won't be able to run a drip. So in that patient, you would do an IV BID or like a 80 milligram bolus followed by 40 BID. But if in a perfect or in a setting where you have adequate IV access and you have you don't have to worry about the national PPI shortages, you would try to do an IV PPI drip for almost every patient. But just with the caveat that data is equivocal. Any questions about that? I know it's little, it's confusing because we don't have consensus, but anybody want to clarify something here? All right. So if you have an IV line, start with a drip. If you have only one, if you have 2 IV lines, if you have one IV line, you won't be wrong for doing IV BID. Okay, I think that's enough. We can now go forward with the case. Nobel, you can start. Nobel? We can't hear you, you're mute. Nobel, can you unmute yourself? Can somebody?
Sorry about that. Yeah. So patient management. So in ED, so initially he got Pepsid and Nalox, and he got Protonix 80 milligram IV. He also got Zofran PO, then IV for vomiting, intermittent vomiting. So we got 2 large bore IV, 18 gauge. So GI was consulted. They said they will do EGD next morning, and they said to continue with Protonix 40 milligram IV BID. Ringer's lactate was started. a few hours later, 100 milliliters per minute, and for back pain, so we were giving Tylenol. So this is the result of the upper GI endoscopy. Next. So as you can see, there's some area of lesion in the esophagus, middle third. And interestingly, you can also see there's some gastric body torsion. And so there was some gastric body torsion, which, and after that, they were able to go to duodenum. And you can see the continuity of the torsion of the gastric bodies. So these were the results. So LA grade D esophagitis, so it's the highest level of esophagitis. It means there is 75%, the esophagitis consists of at least 75% of circumference. There was no active source of bleeding. There was a large hiatal hernia, and 2 liters of black fluid was removed from esophagus. And there was an abnormal rotation of the stomach, which is shown in the twisting of the stomach, and it says it's consistent with gastric volvolus, causing obstruction of the pylorus. But it was not acute obstruction. They were able to go through duodenum. So at this time also, patient was started having like continuous vomiting. So that's why they had to intubate him before they did this EGD, and they also called ICU. And so they were also in contact with surgery because of concern of these gastric volvolus. So surgery was wanted to make sure with CT abdomen about any imaging for the volvolus or not. Interestingly, when we did CT abdomen after EGD, so there was no evidence of organoaxial gastric volvolus, and which reflects the volvolus might be intermittent in nature, not acute. And also they were still saying these diffusely dilated fluid from esophagus, there is a hiatal hernia, and some other incidental finding. And this is the X-ray. So also it's very non-specific, doesn't show any symptoms or any signs of volvolus. So surgery was consulted, and they did operated on this patient at the end. So they did see there was a large paraesophageal hernia. So they did reduction. They also see the gastric volvolus, the part that was herniated into the above the diaphragm. It was volvulized, and they reduced it. They did a fundoplication, which essentially means gastric fundus. They put in front of the lower part of the esophagus, and they suture it. And also they did anterior gastropexy, which means the suturing of the anterior abdomen with the rectus sheet. So I'm going to focus now on hiatal hernia, G junction, and gastric volvolus. So when you think about lower esophageal sphincter, so initially it was thought that it was only made up by lower circular smooth muscle of the esophagus, but there is like current hypothesis is there is like essentially 2 sphincter that makes up this GE junction. So the internal part is lower esophageal intrinsic smooth muscle of the distal esophagus and some fibers from stomach, and the external part is this crural fiber or muscle fibers from diaphragm. So these 2 maintains our GE junction. And so we will now focus on what is hiatal hernia. So there's 2 types, essentially sliding hiatal hernia and paraesophageal hernia. So sliding hiatal hernia we call when there is a displacement of GE junction above the diaphragm. And paraesophageal hernia we call when there is herniation of the gastric fundus as well. So this is the fundamental difference. So type 2 is essentially just the gastric fundus is herniated, but the GE junction is still below that diaphragm. And type 3 is it has both GE junction herniated and the gastric fundus, both are herniated above the diaphragm. And we call type 4 hiatus hernia when there is the height defect is so large that there is also presence of other organs like colon, spleen, pancreas, small intestine. So these are the types of hiatal hernia. So now what actually the reason of hiatal hernia? Okay. So this distal portion of the esophagus is maintained and by this phrenoesophageal ligament. As you can see, it has 2 portions, the upper part and the lower part. This maintains the competence of the GE junction, and it prevents the migration of the gastroesophageal junction and stomach into the mediastinum. So, but as we age, it becomes more and more lax and losing the amount of elastic tissue. So wear and tear is one of the main important reasons of these hiatal hernia. But there is other reasons of hiatal hernia due to laxity of these elastic tissues as well. As you can see here, excessive contraction of esophageal longitudinal muscle, increased abdominal pressure, as occurs in power athletes, pregnancy, genetic predisposition, and previous surgery. So some epidemiological facts. So among the hiatal hernias, 95% are usually type 1 hiatal hernia, and only 5% are paraesophageal hernias. And among that, 90% are type 3. And actually, it's seen that type 1 hiatal hernia is widely prevalent. So it's present in at least 10 to 80% of all North American population. There are some other epidemiological facts. I just put it here, that 20% of the Western population have GERD, and hiatal hernia is present about 90% of patients who has reflux esophagitis diagnosed by endoscopy. Okay. So sliding hiatal hernia is mostly asymptomatic. So only the large.
Your screen is not sharing anymore.
Oh. So it wasn't. Okay.
Looks good now. You can go ahead.
So they couldn't see it. Okay, so I'm going on. So sliding hiatal hernia is mostly asymptomatic. It's large type 1 hernia associated with GERD symptoms. Complications are usually rare and related to reflux. And paraesophageal hernia, it is asymptomatic and have only vague intermittent symptoms. And most common symptoms are epigastric or substernal pain or postprandial fullness, nausea, and retching. But it has some grave complications. So the complications are gastric volvolus, bleeding, and respiratory complication if there is a mechanical compression of lung by large hernia or other organs through the hiatus. So diagnosis of hiatal hernia is usually incidental. We get to see this in X-ray, CT abdomen, manometry, upper GI endoscopy. But more sensitive and specific tests are barium swallow, upper GI endoscopy, and high resolution manometry. So this is usually sometimes we see in hiatal and chest X-ray findings of hiatal hernia. So there will be a rounded and well-defined airfield level in the retrocardiac location. So as you can see in picture here and also lateral view here. So management of hiatal hernia. So usually for sliding hiatal hernia is asymptomatic, so no surgical management needed. And symptomatic sliding hernia will only be treatment for GERD. But in case of paraesophageal hernia, if it is symptomatic, it needs surgical repair. And emergent repair is needed in case of gastric volvolus, uncontrolled bleeding, obstruction, strangulation, perforation, and respiratory compromise. Now, what is gastric volvolus? So it is an abnormal rotation of the stomach of more than 180 degrees, which creates a closed loop obstruction that can result in incarceration and strangulation. It is usually of two types, organoaxial and mesenteraxial. So organoaxial gastric volvolus is when there is a rotation around the line extending from the gastric cardia to pylorus. So the rotation will be from greater curvature to lesser curvature here. And mesenteraxial will be a rotation around the short axis. So from the pylorus or antrum towards the cardiac portion. So that's mesenteraxial gastric volvolus. And it might present with classic triad of Burchard, so which is severe sudden epigastric pain, intractable retching, but no vomiting, inability to pass an nasogastric tube. And the more chronic symptoms are usually present in patients with mesenteraxial volvolus. So these are some findings you can see in chest X-ray. So you can see a mediastinal or retrocardiac airfield level on chest X-ray. And if you do abdominal X-ray, so these are the signs you can see, double bubble sign. And this is a barium study, which shows where is the constriction part. So as we say, this is an abnormal rotation of the stomach, more than 180 degrees. And mostly it is organoaxial or 59%, mesenteraxial 29%, the rest are mixed. And mesenteraxial volvolus is more likely to be found in pediatric population. The risk factors are age over 50, gastric ligament laxity, so think of hiatal hernia, as in this case, pyloric stenosis, rectal atresia, gastroduodenal tumor, diaphragmatic injury, and eventration, which means elevation of the hemidiaphragm, and left lung resection and pleural adhesions. And the complication of gastric volvolus can be bowel obstruction, strangulation, ischemia, necrosis, perforation, and abdominal sepsis. And this is a medical emergency, and the mortality rate is very high, as can be like 30 to 50%. So diagnosis is usually by imaging, so mainly by barium upper GI series. If we do CT abdomen, we can see gastric malrotation, and it can define the transition point where it says it mesenteraxial or organoaxial. It can sometimes also be diagnosed through upper endoscopy, as it initially, as we've seen this patient, we have seen through upper GI endoscopy, and we have seen this tortuous appearance of stomach, difficulty or inability for the endoscope to reach the pylorus. And management is primarily surgical, and it involves decompression of the stomach, volvulus reduction, possible gastropexy, and gastrostomy tube placement. And if there is intra-abdominal defect like hiatal hernia, it should be corrected as well. So our take-home points for today. So GI bleeding patient usually doesn't present with constipation. So if there's a constipation, think about obstruction. So hiatal hernia is a highly prevalent condition, as we said, like 10 to 80% of people have hiatal hernia, and it increases as we age. And the presence of hiatal hernia is a poor predictor of abnormal gastroesophageal reflux or reflux esophagitis. And one of the grave complications is gastric volvolus, which is a medical emergency and needs a prompt surgical management. And if we do CT abdomen and abdominal X-ray, it may not be significant in case of intermittent gastric volvolus, as we've seen this in this patient. So we could not see an acute volvolus because it was intermittent in nature, but still it needs surgical intervention. So that's pretty much it.
Great presentation, Nobel. Great GIF as well. So I just want to talk about that last take-home point. So as we said, can GI bleed? This patient had 3 days of constipation. Can a patient with a GI bleed, will a patient with a GI bleed present with constipation? Why or why not?
So usually it's the GI, the bleeding, the blood is usually stimulant. So patient should not have constipation at all. So exactly. In this case, this patient had constipation.
But that's very important to know. If you suspect that a patient is having a GI bleed or an overt GI bleed, they would hardly ever have constipation because blood acts as a laxative. Blood in the GI tract acts as a laxative, which stimulates bowel movements, and you would see that blood manifests as a black bowel movement or hematophysia. Anybody want to, Nobel, not you, anybody want to comment on why this patient did not have overt melena or blood coming from the lower GI tract? Because it's very atypical that this patient did not had such massive, yeah, good point. Joe, can you tell us, can you unmute and tell us what do you think?
If, well, this patient had an obstruction with the centerman and volvulus seen on the EGD, so that would prevent blood from going down and pooled in the esophagus and the stomach.
Absolutely. So when we put in the scope, we saw 2 liters of blood all pooled in the stomach. So that blood could not go down that obstruction, and it was pooling there. If this patient did not have an obstruction, this blood would have gone down and would have manifested as melena. So this patient is atypical because this patient had a proximal bleed and a distal obstruction. That's why, but in a regular patient with a GI bleed, you would never see constipation. That's just one more point I wanted to tell you guys. All right, it's been very long, but great case, Nobel. Thank you everybody for joining and participating.